dear friends. Today we are going to study peptic ulcer. In this discussion, we will cover the definition, etiology, types of peptic ulcer, signs and symptoms, complication, diagnosis, and finally we will be covering the management of peptic ulcer. Let us see what is peptic ulcer. The word peptic means pepsin, a stomach enzyme, and ulcer refers to a kind of erosion. We can define peptic ulcer as the formation of lesions in the lining of GIT, typically in esophagus, stomach, and the duodenum. Hope you are clear with the definition. Let's move and discuss about the etiology. The most common etiology is H. pylori, Helicobacter pylori. It is a gram-negative extracellular bacteria. As many as 80% of ulcers are associated with H. pylori. Next is lifestyle. The lifestyle reasons are smoking, alcohol, and stress. Increased usage of drugs like NSAID, non-steroid anti-inflammatory drugs, anti-cancerous drugs also worsens the peptic ulcer situation. Schollinger-Ellison syndrome. This is a tumor which increases the stomach acid, leading to peptic ulcer. Now we shall see what are the types of peptic ulcer. Mainly we have duodenal ulcer and gastric ulcer. As said in the definition, typically it occurs in esophagus, stomach, and the duodenum. Esophagus is least affected, so we will be only discussing about stomach and duodenum. The most common location of duodenal ulcer is anterior wall of duodenum. To be precise, the first portion of duodenum. And the gastric ulcer occurs in the lesser curvature of stomach. Let's see an image of stomach. This is the esophagus, fundus, cardia, body of the stomach, antrum, and this is the greater curvature, and this is the lesser curvature, which is the most common location for gastric ulcer. And this is the first portion of duodenum, which is the common location in gastric ulcer. The duodenal ulcer. The most common cause in duodenal ulcer is H. pylori. Gastric ulcer can be also caused by H. pylori along with NSAIDs and smoking. The epigastric pain. This is different in both duodenal ulcer and gastric ulcer. Epigastric pain relieved with food in case of duodenal ulcer. That makes sense. If you have eaten more, pain decreases, so you will try to eat more. It leads to weight gain. And in case of gastric ulcer, the pain worsens with food. So the patient tries to reduce eating, leading to weight loss. With food, pain decrease leading to weight gain. Hope that makes sense. With food, pain increase leading to weight loss. Burners gland. It is a duodenal gland secreting mucus and alkaline fluid. It is duodenal ulcer causing the hypertrophy of Burners gland. So the hypertrophy is only seen in duodenal ulcer, and gastric ulcer not usually show hypertrophy of Burners gland. The main signs and symptoms. Epigastric pain. As I said earlier, epigastric pain is different in duodenal and gastric ulcer. Bloating, hematemesis and melena. Hematemesis is vomit of blood, and melena is a tarry, foul smelling stool. It is due to the presence of oxidized hemoglobin. Let's move and see the complications in peptic ulcer. Mainly we have 5 complications: upper GIT bleeding, malignancy, perforation, penetration, and last is gastric outlet obstruction. Let's see one by one. Upper GIT bleeding. The blood vessels damaged by the ulcer erodes into the muscles of stomach and duodenal wall. Here the difference is duodenal ulcer can lead to erosion of gastroduodenal artery, but the gastric ulcer lead to the bleeding in left gastric artery. Gastroduodenal ulcer. Gastroduodenal artery. And in case of gastric ulcer, it is left gastric artery which is ruptured. This is important, keep this in mind. And the next one which we will be discussing is malignancy. Malignancy is most commonly seen in gastric ulcer and not seen in duodenal ulcer. Perforation. Perforation is a hole in the wall of GIT. Bacteria and partially digested food spills into the peritoneum, leading to peritonitis. And in penetration, the ulcer can continue to the adjacent organs like liver and pancreas. In gastric ulcer, it most commonly penetrate into the left lobe of liver in gastric ulcer. And in duodenal ulcer, it penetrates posteriorly into the adjacent pancreas, leading to pancreatitis in duodenal ulcer. And the last one is gastric outlet obstruction. And what do you mean by gastric outlet obstruction? It represents a clinical and pathophysiological consequence of any disease process which produces mechanical impediment to the gastric emptying. Hope that's clear. Here in duodenal ulcer, which is the most common cause of pyloric stenosis than gastric ulcers. Okay. So in gastric outlet obstruction, the patient often presents with recurrent vomiting. Due to vomiting, the HCl content will be decreased, leading to metabolic alkalosis. This is important, keep this in mind. And because of vomiting, decrease in fluid also occurs. which result in dehydration, which leads to activation of renin-angiotensin system, results in increase of sodium and water reabsorption. Because of the sodium and water is reabsorbed by the kidney, potassium is lost. That means potassium is decreased in the blood. It leads to hypokalemia. So you should know why hypokalemia and metabolic alkalosis occurs in peptic ulcer. The next is diagnosis. First, it is breath urea test. It is a non-invasive procedure. Let's first see what H. pylori normally do in stomach. Urea is converted to ammonia and carbon dioxide by the enzyme urease, and this urease is produced by the H. pylori. So here in breath urea test, patient is given a radioactive urea mixed with water. Further, the patient will be asked to blow into a balloon and the radioactive CO2 is measured. What actually happens in stomach is radioactive urea given to the patient is converted to ammonia and carbon dioxide. The radioactive carbon dioxide is absorbed to blood from the stomach and then to the lungs, and from lungs it is exhaled and it is measured. This is what happens in breath urea test. Next is a rapid urease test, or also known as clot test. In rapid urease test, this is performed at the time of gastroscopy. A biopsy of the mucous membrane is taken from the antrum into a medium containing urea and an indicator. The presence of H. pylori converts the urea into ammonia and carbon dioxide. The presence of ammonia, which change or raise the pH, and yellow color will be changed to red. If it is yellow, that is negative, and if it is red, it is positive. That means in the presence of H. pylori, the urease will be converting the urea into ammonia and carbon dioxide. As I said earlier in breath urea test, the mechanism is similar. So the yellow color will be stating that negative test for H. pylori, and red will indicate that the H. pylori's presence is found in the stomach or the duodenum. And next is stool examination, and the final and the most important test is endoscopy with biopsy. This is the investigation of choice. What actually happens in endoscopy? In endoscopy, a flexible tube fixed with camera is threaded down to the esophagus and then to the stomach to see the ulcer and evaluate the stomach mucosal lining by the physician. And the last and the final topic is management. Management mainly involves lifestyle changes. Lifestyle modification is very important. First one is lifestyle management. cessation of NSAIDs, smoking, alcohol will improve the situation in peptic ulcer. And the next is medical management. Here we have two regimes: triple drug therapy and quadruple drug therapy. In triple drug therapy, we have three main drugs, that is pantoprazole, clarithromycin, and amoxicillin. Here pantoprazole is PPI, that is proton pump inhibitor, and clarithromycin and amoxicillin are antibiotics. Don't confuse clarithromycin with erythromycin. Both are macrolides, but erythromycin is not usually used in triple drug therapy. And the next one is quadruple drug therapy regime. Here we have 4 drugs, as the name suggests: bismuth, tetracycline, metronidazole, pantoprazole. So let's recap what we have learned. Before that, this triple drug therapies and the drugs included in triple drug therapy and quadruple drug therapy is very important. Let's recap what we have learned. The main location: esophagus, stomach and the duodenum. Most common risk factor: H. pylori, which is a gram-negative extracellular bacteria. And this table: the difference between duodenal and gastric ulcers, which artery rupture occurs in duodenal ulcer and gastric ulcer, which will be leading to malignancy, why metabolic alkalosis and hypokalemia occurs in peptic ulcer patients, how we do breath urea test, rapid urease test, and what is the investigation of choice in endoscope in peptic ulcer. Management: in that, medical management including the triple drug therapy, quadruple drug therapy, all these names should be remembered because it's usually asked in MCQs and all. So thank you friends. Before concluding, let me remind you, in next video we will be talking about the peptic ulcer treatments. We will be studying the most common mechanisms of drugs which act in peptic ulcer. Okay, so until we see next time, bye.